My name is Dr. Art Rastinehad. I'm from Northwell Health. I'm the Vice Chair of Urology for the Smith Institute, as well as the System Director for Prostate Cancer. Looking at unfavorable intermediate risk prostate cancer, comparing it to the more high risk profile, what's the difference? Prostate cancer specific mortality. The difference for favorable is 5 to 10% could die from the disease, but 15 to 25% could die of prostate cancer if they have unfavorable intermediate risk prostate cancer. Also, with prostate cancer screening, the goal was to prevent metastatic disease. Of course, when you have two different types or risk categories of prostate cancer, the favorable intermediate, there's a 5 to 15% chance that it's going to spread, but it's a little higher in the unfavorable group, 15 to 25. (10 to 30% of patients after therapy may have a recurrence of their PSA, or in the unfavorable, 30 to 50%. This data that I've just discussed is based on 10-year data. It's aggregates of surgery, radiation, so it's really hard to tell. But we do understand there's a certain biology or the disease behaves in a specific way that we want to make the differentiation between that favorable intermediate and unfavorable intermediate risk prostate cancer. High-risk prostate cancer is Gleason 8, 9, or 10. We looked at that at 10-year data. It has almost a 30 to 50% chance of dying from prostate cancer in 10 years. So as you're starting to understand and see here, grade matters, and the stage or the risk strata category that you're placed in will impact your decision making. The risk of it spreading is also 30 to 50% of high risk compared to the unfavorable intermediate risk prostate cancer, which is only 15 to 20%. And lastly, when we talk about therapies, if you're having surgery or radiation, you have a 50 to 70% chance that PSA could return. And there's a lot of nuance to this, but I just wanted to give you an understanding of what we see here today. And I think when you're the patient, it's a challenge. What decisions, what options do I have? You're the man in the middle. You have prostate cancer, should you have a radical treatment or active surveillance? That's really where we are. And focal therapy may be that middle pathway where you can get a cancer control without having to undergo the unnecessary or unwanted side effects of radical treatments, which could be leakage of your urine, erectile dysfunction. You could have rectal toxicity from radiation, but also the cost and the issue of overtreatment. Not every patient needs to have a radical therapy. Why focal? I believe it's changing the face of prostate cancer because we understand as urologists and people that treat prostate cancer, a lot of patients are overdiagnosed and overtreated. And how can we minimize these effects? The sexual side effects, the erections, as well as urinary incontinence. Focal therapy has those options and those are the outcomes. Again, as I said prior at the beginning of the video, it can be an outpatient same-day procedure, get you back to work sooner with less of side effects. And sometimes we perform focal therapy without even a urinary catheter. And a urinary catheter is a tube that drains your bladder that we attach to your leg after, for example, if we did surgery like a radical prostatectomy. What we're really looking at now with the Focal Therapy Society is looking at durability and cancer control over time. The results are very promising, but they're still early, and we are excited to see the direction that this is going.